My name is Terry King. I am the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute, and the Vice Chair for Multidisciplinary Oncology. So when chemotherapy is used before surgery, or we say neoadjuvant chemotherapy, when one of the most important aspects of then planning for surgery after treatment is to try to understand the response that has taken place either in the breast or in the lymph nodes or in both. And so we use imaging. We use imaging obtained prior to starting the chemotherapy and imaging obtained then after the completion of the chemotherapy to assess what we call the radiographic response. How does the tumor look on the MRI before treatment and on the MRI post-treatment, or the mammogram before treatment and the mammogram post-treatment, to give us a sense of how much shrinkage, how much smaller does the tumor look, and does it look like we could perform a lumpectomy, or does the patient still require a mastectomy? So radiographic response helps us to make our surgical treatment recommendations and explain the options. If it looks like someone has had a complete response radiographically, that means that there's no longer any evidence of a breast mass or any evidence of what we call enhancement on the MRI, then that is obviously an ideal candidate to perform a lumpectomy and preserve the rest of the breast. And when we perform the lumpectomy in that case, we're doing it to just get a sample of the tissue where the tumor used to be to actually confirm that it's completely gone. So a radiographic complete response is not 100% proof that all of the cancer is gone. You still do need to have a surgical procedure to sample the tissue to look for a pathologic complete response. So pathologic complete response is when under the microscope, the pathologist can no longer see any evidence of viable cancer cells. And so when that happens, that's an excellent that portends an excellent prognosis for patients when treatment has completely eradicated the disease, but that doesn't always happen. And so there is frequently some amount of cancer left behind. And so then in those cases, it would be considered a partial response. So not all of the disease is gone. Some of it has been treated and some of it's been killed. And the pathologist tries to quantify that for us on the pathology reports with different ways of measuring how much disease remains in the breast. So we have radiographic complete response or radiographic partial response. And we use that information to plan our treatment recommendations. If someone has not had a good response and they still have a large tumor in the breast, then I might need to still recommend mastectomy. Whereas if someone has had a nice radiographic response and I can see that that mass has shrunk down very nice, or that enhancement has disappeared on the MRI, then I would like to recommend a lumpectomy for that patient. Similarly, if someone starts out with lymph nodes under their arm that I can feel, and we biopsy them and we know that they have cancer in the lymph nodes under the arm, if they have a complete clinical response, meaning they come back to see me after chemotherapy and I can't feel those lymph nodes anymore, then that's a patient that I'm going to offer a sentinel lymph node biopsy procedure to, where I would just remove the node biopsied and positive, and I would also remove the sentinel nodes, which are the first two those nodes while we were in surgery. And if there was no longer any evidence of cancer in those nodes, then I would not need to perform any further lymph node surgery. Whereas if someone sees me after treatment and I can still feel that abnormal lymph node under the arm, then they've not had a complete clinical response. And then in that situation, I would still be recommending full lymph node surgery to remove that disease. So to summarize, there again are different measures of response. We have radiographic complete response and radiographic partial response. We have pathologic complete response, which is all evidence of disease is gone under the microscope, or pathologic partial response, where there's still some viable disease, but some of it has been treated. And then there's also clinical response, where we are feeling the lymph nodes or feeling the size of the breast tumor, and you making a clinical determination of what needs to follow in the surgical recommendations based on that clinical response.